right, welcome to another episode of Back Talk. I'm Dr. Jason Velez with Resurgence Orthopedics.
And I'm Dr. Chris Blanchard with the Resurgence Orthopedics and the co-medical director of the Resurgence Spine Center.
And we're here to talk about spine surgery. And the topic of today's podcast is that this is not your grandmother's spine surgery. And the point of this conversation is to, bring up the fact that spine surgery has come a long way.
Absolutely.
In many years now, and to try to take into account and dispel any of the myths that may still linger about back surgery being bad. So that's our point today.
Yeah, with that being said, Jason, let me ask you this. When you were in residency, what was your experience with spine surgery patients? How long did they stay in the hospital? What was their sort of recovery afterwards?
Gotcha. So, we just got electricity and we were bringing them in on the wagon. And basically, it was a big endeavor, big incisions, a lot of dissection of the muscle, which led to a lot of back pain afterwards. And just like with a lot of joint replacement surgeries, patients were easily in the hospital 3 to 5+ days before they would even go to a rehab, which was often required. So that was, I know I got some years on you, but I was just at the end of my training starting to transition to things being more outpatient, but still far off from where they are now.
Yeah, and I would agree. I think my experience in residency was very similar. It was sort of every patient that had a lumbar fusion spent 3 days in the hospital. They had to spend 3 days before they went to rehab. And so you just knew on day 3 you were going to discharge them to rehab. And so it was a very traumatic episode for the patient where they knew they were going to be in the hospital for 3 days. Nobody wants to be in the hospital for 3 days. And so, yeah, I would agree. My experience was very similar, which sort of led me to a lot of the things that I do today, just thinking, man, if I were having surgery, I wouldn't want to be in the hospital for 3 days just after a, somewhat routine elective spine surgery.
Right. I mean, no one necessarily wants to be in the hospital. I wouldn't elect to be in there for longer than I had to. So, that the transition to a lot of these patient treatments being outpatient, really occurred. I don't know. I guess it would have been mid-teens where it was really taken off. Because I really had very little, if any, minimally invasive experience in my fellowship, let alone my residency. But you were starting to see a little more of that.
Yeah, I think coming out of, didn't really see much in residency, but like you said, sort of mid-teens. I was in fellowship in 2017 and did start to see more of that transition to outpatient surgery or surgery that may be what we call 23-hour OBS, where they're in the hospital overnight, home the next day. And just seeing such a big difference in how those patients recovered from surgery was huge.
Yeah.
They're up walking quicker, they're recovering quicker, they have less pain afterwards. And so it makes patients, I think, less hesitant when they understand, hey, this isn't the same surgery that was done 15 or 20 years ago. And now there still are some procedures that are very similar, but seeing that in fellowship really, sort of opened my eyes to what we could do in spine surgery. And I think you made a great analogy when you said like joints. Well, when I was in residency, joints were the same way, total joint, total knee, or total hip, hospital for 3 days and then to rehab. And now kind of in the same manner, a lot of them are outpatient home the same day.
Exactly. And then, having to check Coumadin and all that stuff is always painful. But, the not to get all philosophical, but the history of human evolution is, our ability to create, and imagine things generally far outpaces our ability to understand appropriate use. So, just because we have a hammer, not everything is a nail.
Right.
So, while it's important to note that we have all these procedures, I can speak for myself, and I have to assume you're the same. You have a lot of knowledgeable people out there because access is very easy these days, expecting and wanting certain things that would fall into that category, but they may not be the best person or best candidate for that procedure for any number of reasons.
Yeah,
so sometimes the old stuff is still good.
Absolutely. And I think, when I was in fellowship, I told one of my mentors, I said, hey, I really thought when I came to fellowship, you guys were going to tell me the right answer. And all you did was give me more options of things to do, which was fantastic.
It's like an episode of Kung Fu.
Yeah, exactly.
It's like grasshopper.
Yeah. So the other thing that that was also very, sort of a center thought of minimally invasive surgery was you have to be able to accomplish the same goals as a regular open surgery. And so if you can't accomplish the same goals and you don't get rid of the patient's leg pain or arm pain, and you're doing a minimally invasive surgery, well, that's not doing anybody any good. So you still have to accomplish the original goals of the surgery. But if you can do it in a less invasive manner and allow the patients to recover quickly, that's fantastic. But just like you said, it's another tool that we have, but it's not the answer for everything.
Right, exactly. Then you look at progress of implants. Now we have disc replacements as opposed to fusions, which offers another option. Mm-hmm. We have robotic treatments with placement of pedicle screws and allowing for more accurate placement of these hardware devices. There's a glut of options out there, and again, I spend a lot of time with my patients just explaining, okay, I hear what you're saying. This is my thought. This is why I think this may be better. Or saying, yeah, no, you're right. You're a great candidate for that. It still comes down to our discussions with them.
I 100% agree. And another thing that I think you're seeing right now in spine surgery is, we've gone from open everything to minimally invasive in a lot of procedures. Now there's this big push towards endoscopic surgery.
Oh, yeah.
And, I think there's probably a place for that. But again, kind of just like you were talking about, it's a discussion that you're having. And if it's not going to change the patient's outcome, recovery, or anything like that, that's the conversation you have. Well, okay, is this more beneficial? And with the healthcare environment the way that it is, cost becomes an issue, right?
100%, yeah.
So when we're talking about, getting patients out of the hospital and recovered quicker, well, that's less, dollar burden on the healthcare system. And that makes a huge difference.
Yeah, no, 100%. And there's a lot of hospital systems out there pushing, streamlining everything down, using a limited number of options for implants, even so much as, making sure that comparing your cost per procedure with your peers. Mm-hmm. Some of the hospital systems even post it right there in the order set. This is your average, this is your peer's average, and this is the national average. And to whatever degree that's a game, to play to try to get yours more in line, or feel very confident that, hey, you're getting very good value for your price compared to the other people. It does help move the needle in the right direction.
Let me ask you this. Do you have one procedure or spine surgery that you've seen transition more towards the surgery center or outpatient basis that's maybe your favorite to do, or the thing that you've seen change the most?
Yeah, well, just to preface this, again, I really had no minimally invasive training in my fellowship. Very, very little. Mm-hmm. Laterals were just starting out. Sub-tube-based stuff for foraminotomies, but that was it. So I kind of had to self-teach myself MIS TLIF fusions. But I would say that aside from that, we were ahead of the curve. Most all of our cervical fusions were outpatients.
Yeah.
Even up to 3-level ones were outpatients same days. So that's one that I've always felt comfortable with right off the bat. I had to cut my teeth a little bit in the hospital setting with these MIS fusions until I felt comfortable and confident enough in the procedure itself, not my ability, but the procedure that I could do it in the outpatient surgical center, go home the same day and not worry, because ultimately I really care about what I do, and I carry that burden with me every night to bed. So I want to make sure that, not only is the patient well, but as a result, I get a good night's sleep.
Right. And I think that's a good point that you made with where we are sort of in the evolution of minimally invasive spine surgery, right? We're not in the very early stages of it, but we're also not at the end of the evolution. And so most of the things that we do have good research behind them. We've, done several studies about patient outcomes with them. And so you start to have a better handle on which patients are going to do well with it, which patients may not be the best candidate for it. So we're sort of standing on the shoulders of our predecessors in a way, because we have all of that information, just like you said, coming out of fellowship with the cervical spine surgery, being much more comfortable with sending those patients home the same day and sort of a more rapid recovery.
Right.
And so as that's evolved with lumbar fusions or even lumbar disc replacements, discectomies, laminectomies, having that experience and the years of research that we have now on that makes that transition much easier to do from the inpatient hospital setting to the outpatient setting.
Yeah. And I think, like you said, the research is there. It shows that the outcomes are equally good as long as the patient selection is on par with with that. Unfortunately, some people are just not good candidates either because of health issues or body habitus, or just, we're trying to expect too much from a procedure that really should be a little more open.
I think one of the things that's interesting to me and what I see is that a lot of times when we're doing minimally invasive surgery, right? So if we're doing a minimally invasive lumbar fusion, well, a patient may have 2 or 3 incisions as opposed to just 1 incision. And so explaining to them, hey, you're going to have, sort of 2 small incisions and then maybe 1 small incision on your side. And they're going, well, wait, what do you mean? How is that minimally invasive? Why do I have 3 incisions instead of just 1 incision? And sort of walking them through the understanding that, you can have 1 incision this big in the middle of your back where we go down and peel away all of the muscle off of your spine to do the same work, or we could make a couple of smaller incisions and essentially just split through the muscle with your finger and not damage all of that muscle and peel it away. And then they start to go, oh, okay. Yeah. So it's not necessarily about the number of incisions. It's about everything that happens under there.
Right, exactly. Because some of my incisions, when I do the screws going through the paramedian incisions, I'll just connect them because the 2 incisions are too close. They're not going to heal.
Right.
So you got large incisions like that, but really it's just on the skin, and everything else underneath is just little poke holes. So, it's all about letting them know it's muscle sparing, which is going to increase, their ability to get up and move, and ultimately not, have a speedier recovery and not have so much back pain that typically comes after the surgery. But, that's a discussion that, a lot of them seem to understand. And again, the biggest thing that I run into really is just getting patients to understand that, primarily we're doing this surgery not for back pain, but more for the nerve symptoms that originate from the back pain.
Yeah.
And, that's another topic of discussion that typically is an issue. And, I think feeds a lot of that fear that people come in with. It's like, hey, my grandmother, my cousin, my uncle's brother's roommate, they had, this surgery and they still had back pain.
Right.
Well,
it
could happen.
Yeah.
If you're cutting the muscles open and all that stuff too.
And I think that's one thing that, you have to be aware of the indications for the surgery, right? So minimally invasive capabilities don't necessarily change the indications for surgery, right? So we used to think 20 years ago, well, if you had arthritis and you have back pain, you should have a fusion. And I tell patients every day, your grandmother that had that surgery, that's probably what she had it for. And then our research came out and showed us, those results really weren't that good.
Yeah.
And if you think about all of the soft tissue and muscle damage that's created by those procedures, then you kind of go, oh yeah, well, no wonder they still had back pain afterwards.
Right.
And so it doesn't change the indications for surgery, and you still have to be able to accomplish the same goals. But if we can do it in a less traumatic way, less soft tissue damage, quicker recovery, outpatient basis, save healthcare dollars and pain afterwards, it's a great option for a lot of people.
Yeah, no, I mean, I think it's just going to continue to evolve. I mean, that's just the nature of humanity, But fear is also a very potent motivator, both good and bad. And a lot of it, I always tell people, the surgery is the easy part of what I do. Okay, I consider myself more a psychologist most of the time because I'm having to walk through a lot of these issues and get out in the weeds and what are you afraid about. What drives your concern here, and how we can move beyond that? Because otherwise, people are just going to continue to be scared.
Right. And I think as we see our research drive our decisions, we're going to see better patient outcomes. And then we're going to have more patients out there that are saying, oh, no, I had back surgery and I'm doing great, as opposed to, patients that have had back surgery maybe for poor indications or, big traditional open surgery that their results may not be as good out there saying, oh, no, I had back surgery and I still had the same pain and it really didn't help. And so I think you're going to see that trend as we understand more the predictable indications for surgery. I think you're going to see patient satisfaction continue to grow with that.
Yeah, especially now that it's actually being used as a potential outcome measure for healthcare reimbursement.
Right, absolutely.
People are going to like, it's more than just you being able to execute a plan.
Mm-hmm.
There needs to be value in that, not only monetarily, but patient satisfaction wise.
Right.
So, it's gone are the cowboy days where you just, slinging your gun around the West. You gotta bring it with the outcomes with the patients, which again is another reason to really sit and talk to your patients and say, hey, let me establish a set of reasonable expectations.
Right. And I commonly tell patients, hey, I would much rather set your expectations here and deliver here than the other way around. Because if we do it the other way around, you're not happy. If you're not happy, I'm not happy. And so I, just like you, spend a lot of time with patients. Hey, here's the expectations. Here's what things are going to look like the night after surgery, the week after surgery, 6 weeks after surgery. And setting those expectations makes all of the difference. If you tell somebody, hey, you're going to have surgery, the next day you're going to feel like you were 18 again, well, and they don't, well, now they're not happy.
Right.
But if you tell them, hey, your leg pain's going to go away, you're going to have some back pain from surgery, that's going to get better as you recover, you're going to be home the next day or that same day, and you meet those expectations, now all of a sudden they're a very happy patient.
Exactly. I mean, it's a relationship like any other. You got to put in the time, you got to put in the effort. If you're dating, love bombing is a red flag. If you go into an office and the guy's like, oh, I take care of this for you next week and I'm going to promise you the moon and stars, probably get another opinion.
Right.
Which I would recommend everyone do anyway.
Yeah.
I encourage my patients, look, this is just my opinion.
Yep.
And these are my skills. Like, I'm not a 9-inning pitcher. I'll get you a good 6 or 7.
Yeah.
Okay. I know what my skills are.
Right.
And I think that's a reasonable thing. And I think a lot of patients may be a little afraid to put their surgeon on the hot seat and be like, hey, look,
Right.
How many of these have you done? Or,
Yeah.
how comfortable are you with this procedure?
And I think those are all very valid questions. And I tell patients all the time, hey, if you even think about getting a second opinion, go get one.
Yeah.
If I'm telling you the right thing, somebody else should be telling you the right thing as well. I also tell them, though, that if you saw 5 spine surgeons, you probably get 7 different answers on what they would do or how they would do it.
Yeah.
So there does have to be some understanding of kind of the nuances.
Some limit.
Yeah, right. About how they were trained, what they prefer to do. And so I absolutely agree with you on that. I saw a patient today for her, for a 4th opinion, but she had sort of 2 on one side and 2 on the other. Now, what you do with that, I don't really know, but
go for a 5th.
You're right. Yeah. I guess get the tiebreaker. So, but I would absolutely agree with that. You should definitely be comfortable with what you have done, your understanding of why you're having it done, and then who's doing it.
Yeah, no, exactly. And, a lot of times I'll tell patients, look, you definitely need a fusion.
Mm-hmm.
You can get multiple opinions. You're all going to get fusion. You just may get 3 different ways to do it.
Exactly.
Right. And I'm just telling you the way that I think I do it the best in your situation.
And I think that's, sort of around the conversation of minimally invasive surgery, fusion comes up a lot, right? And I will tell patients, hey, you have some instability or some deformity in your spine, and really you need a fusion. And from the moment I say fusion, you can just see this look kind of wash over their face like, oh, no, I don't want that. That's what my grandmother had. And that's what, and going into that conversation with them about, hey, a fusion is not a bad surgery. And I'll commonly tell them, hey, you don't want a fusion or a disc replacement or a discectomy. You want your symptoms to go away, right? You want whatever procedure you need to have to get your symptoms to go away. And if we can do the least invasive or the least amount of surgery, that's our best option. But fusion is not a bad surgery. I mean, we talk about Tiger Woods and Peyton Manning, these, professional athletes that have had fusions and won the Masters and won the Super Bowl. And so around that conversation of sort of minimally invasive, also
Manning's defense won the Super Bowl.
Well, I mean, I won't disagree, but having that conversation with them around that, not just the minimally invasive aspect of it, but the indication for it, and then what the outcome with that is going to be. Because the goal of whatever procedure we're doing is to improve your pain, improve your quality of life, get you back to doing more of the things that you want to do, not, oh, I've had surgery, I can't go do that. Because if that were the case, well, yeah, let's just not do it to begin with.
Yeah. Why are we even here having this discussion? But yeah, I mean, I think, again, just more and more is going to develop. I think, one thing certainly I always have to clarify with patients is they think about robotic surgery and they're thinking about it being like this whole, computer game, video game kind of scenario, which it can be in other aspects of medicine, but in spine surgery, it's really kind of a misnomer.
Yeah.
It's really more to help with placement of some hardware, but you're still requiring incisions, the same as you would even if you did it without a robot most of the time.
Right.
The robot just enhances the accuracy.
I think one of the things that I love about spine surgery in the era that we're in is seeing all of the different developments, right? Now they call them enabling technologies, whether it's navigation or robotics. And I get the question a lot about, oh, do you do robotic spine surgery? And I usually tell patients, hey, I've done robotic spine surgery, but at this point in time, it doesn't add anything in terms of invasiveness or recovery. There's, some argument of, is it more accurate, but with navigation, is that really changing anything? And so with any technology, just like you said, if you have a hammer, everything can't be a nail. With every technology, you have to really evaluate, okay, is this changing my practice and changing my patient's outcomes? Or is this just another tool that we have? And I completely agree when it comes to robotics, what patients commonly think of with the Da Vinci robot and sort of abdominal surgery, tiny little incisions. if we had that, that would be fantastic. Robotics and spine surgery, as you know, it all it does is hold a little rod for you where you can put a screw in. That's really it. And like you said, still the same incisions. I've actually found it to be more difficult to do sort of paramedian or Wiltsy, minimally invasive incisions, because then you pull on the skin, that throws the robot off, and you spend all day fighting with that. So with any technology, you know, you don't want to be the first one, but you don't want to be on the end of it either. And so finding that sort of comfort zone where you can recognize, hey, this is a really good technology or procedure to use, and get on board with that, but also not being the first person to jump on every new trend that comes out.
Right, exactly. I had a patient that I saw just last week. She had one of the original Charites, and I think you saw her too at one point. But you know, it's one of those things. It's like, yeah, it's off the market now. You know, and just like Harrington rods and all these other things, you know, the first one through the door is going to get a bloody nose. All right, but we learn a lot from that. Unfortunately, you know, some of these people have these devices in them, and by and large, it's not going to be an issue. But as new trends come out, you know, like I said, we have not gained a firm understanding of their best uses. And sometimes that occurs years later.
Right.
Disc replacements, for example, right now, we have good 25 plus year data on some of the lumbars and the cervicals. But okay.
And that's what, because I commonly get the question about disc replacements with patients. Well, how long is this going to last? And my short answer is, I don't know. But
at least 15 years.
But like
right
you
now.
know, like you said, we've got good 25-year and 20-year data, survivorship data on those. And had a patient just the other day, and I was seeing him for his neck, but he told me he had previous lumbar spine surgery, and he said I had a 4-level disc replacement, and I was like, well, that's not really possible. And, you know, commonly patients will get some things, you know, sort of miscommunicated. And I was like, a 4-level disc replacement. He goes, oh, yeah, I got the x-rays. And he shows me these x-rays. I went to Germany and had this. And, you know, he had a 4-level disc replacement. And he's still in pain management for low back pain. And so figuring out those things, you know, being an early adopter of them, but also understanding the data and the research behind it, what's going to give patients predictable outcomes is more important than being, you know, the first one on the block doing it.
Exactly. Well, I mean, I think in short, again, we've come a long way. There's a lot of good options out there for people. It's so much easier to do some of these procedures than once they were, and the recovery is much better for a lot of patients in the right amount, or, you know, in the select patient, the right patient for the procedure. And that's ultimately, again, what we're trying to achieve here. So, I mean, I think certainly have the discussion with your physician, and just be open to not hear the answer that you expect, or to be open to hear something that you were hoping to hear. But ultimately, it's a team effort, and we're just trying to work with you guys as patients to get the best outcome.
Yeah, I would wholeheartedly agree, and I think finding the right surgeon with the right relationship, you know, having a good rapport with your surgeon, and knowing and that they have your best interest in mind, regardless of, like you said, if the recommendation is what you want to hear or if it's something else, knowing that, hey, they have your best interest in mind, that makes patients much more comfortable with whatever they're having done. And I think as we continue to evolve in spine surgery, we're just going to see more and more of these procedures move not only from an outpatient or observation basis, but even out of the hospital into surgery centers. That saves a significant amount in healthcare dollars that are being spent. With Medicare the way that it is, any, you know, dollar we can spend or save in the healthcare system is exponentially beneficial.
Yeah, I agree. And to that point, I think I'm going to put in a request to the CEO to do surgery, work from home.
I like that
I'm
idea.
working on that.
I like that idea.
So minimally invasive, I don't even have to leave my couch.
Well, like with the Da Vinci, I guess you could sit in any room you wanted to and just, play on the console.
Just make sure you don't have buggy Wi-Fi.
Oh, good point. Good point.
The buffering will kill you.
Yeah.
All right. Well, thank you for joining us for this edition of Back Talk, and hopefully you find it informative and maybe even slightly entertaining. And again, just speak to your surgeons and get all the information you need, because you need to make that a truly informed decision.
Yeah, and the only thing I would add is, like we talked about with second opinions, I always tell patients, hey, if you go get a second opinion, no matter who does your surgery, at least ask about minimally invasive options and understand that, because if you go to a surgeon who doesn't do minimally invasive surgery, well, you're not going to get a minimally invasive option. And so at least go to a surgeon who does minimally invasive surgery appropriately. And I understand that's kind of hard to know, but at least to understand, okay, is that an option or not?
Yeah.
And then get to make your own decision with it.
Yeah. Or specifically ask why it is or isn't.
Correct. Agreed.